Thank you so much to everybody who is here. My name is Dr. Robin Reed. I'm at Seattle Children's Hospital. I am a pediatric pathologist with a specialty interest in renal pathology, and I will be presenting cases today with some of my pediatric nephrology colleagues, including Dr. Daryl Okamura, who is on the medical staff, as well as two of our pediatric nephrology fellows, Drs. Anthony Salvatore and Stacy Yanofsky. And is this projecting the way that it should?
It looks great.
Outstanding. Okay. We do not have anything to disclose. We are going to start by talking about, as we're going to be presenting three cases today. These are all cases that have come across our, come through our service in the last year. Some of them have a quite long history and are really pretty interesting. So we will start out by talking about a patient who is now 23 years old, who has a 9-year history of lupus nephritis. And this will be presented by Dr. Daryl Okamura.
Actually, Robin, I'll be talking about this one.
Sorry.
No problem.
Oh, yeah, you're right. I'm sorry. I had the order wrong. This will be presented by Dr. Anthony Salvatore. Sorry about that.
All good. Good morning, everyone. I'm Anthony. I'm a second-year nephrology fellow. So our first case today follows a patient with a pretty complex course from 2016 to present, as Robin detailed. Along the way, she had multiple kidney biopsies, and Robin will help walk us through the key findings on some select biopsies. This patient initially presented in Guatemala when she was 14. She had 3 months of joint pain and rash at that time and was diagnosed with class 2 lupus nephritis on biopsy obtained around her presentation. Her records around that time are pretty limited while she was in Guatemala, but notably her initial steroid course was complicated by cataracts and avascular necrosis that would ultimately lead to her requiring bilateral knee replacements in the future. But after she moved to the US, she established care with our rheumatology team at the end of 2016. And at that time, she had arthritis, but otherwise pretty reassuring labs, including normal kidney function and no signs of nephritis. She was on a small dose of steroids at that time. And so a few months later, after her initial rheumatology visit, she received rituximab to help facilitate with her steroid wean. Fast forward about 2.5 years, and in the summer of 2019, she was seen by nephrology for the first time due to nephrotic range proteinuria with a UPC around 2.6. Given the degree of proteinuria at that time, a biopsy was done, and at that time demonstrated class 4 lupus nephritis with 60% endocapillary proliferation and 5% crescents. There was no interstitial fibrosis seen and no membranous findings on EM at that time. But based on those findings, she was treated with rituximab and Cytoxan and then started MMF in early 2020. About 1 month after starting MMF, there was a shift to a more active urine sediment along with increased proteinuria to UPC of around 7 and hypoalbuminemia. And so given the concern for the flare, she was redosed with rituximab and was started on Tacro in addition to her MMF. But however, due to increasing proteinuria, hematuria, and worsening serum albumin, she underwent a kidney biopsy the following month, which Robin will now discuss.
Yeah, so I'm going to be showing you just select kidney biopsies from this patient. As Dr. Salvatore says, there were a lot of biopsies performed along the way. This biopsy from early 2020 shows well-preserved tubules and interstitium, so well-preserved parenchyma. But looking more closely, there was a lot of glomerulopathy here. So you can see in these representative Jones stain images that there was diffuse endocapillary hypercellularity, which you can see in areas like this and this and this. There were additionally pretty prominent membranoproliferative changes. So there was a lot of evidence of glomerular basement membrane remodeling evident on light microscopy. And there were abundant cellular crescents. So about 40% of the glomeruli were involved by cellular crescents. Those are represented, for instance, here and here. And in addition to the crescents, there was also rare focal segmental necrosis, which you can see here in this glomerulus, where there's a little focus of fibrinoid necrosis. Immunofluorescence at this time showed both mesangial and capillary loop staining, which had a full house pattern of which the brightest component was C3, but there was also prominent IgG and IgM and C1q staining. IgA was a bit fainter, but was definitely positive. And finally, electron microscopy shows pretty prominent, kind of chunky electron-dense deposits that you could see predominantly in the subendothelial and mesangial distribution. And then here is again showing large, abundant deposits within mesangium here and here. There were rare capillary loops in which there were subepithelial deposits. There had been a question of whether there was a component of membranous nephropathy in this case, but this was definitely a distinct minority of capillary loops. So this was signed out as diffuse proliferative lupus nephritis. This is class 4 with 40% cellular crescents and also rare segmental necrosis.
So based on those findings, she was treated with another round of Cytoxan, and she did show some improvement both in her urine sediment and proteinuria. Unfortunately, about 8 months after that biopsy that Robin just showed, she was admitted due to elevated creatinine and a low serum albumin, which was concerning for another flare. She underwent another biopsy at that time, which showed an improvement in her crescents with about 2 to 5% crescents and less endocapillary involvement at 20 to 30%. Based on those findings, she was treated with obinutuzumab and steroids. And for the next 2 years, she remained on Tacro and MMF, and she actually did quite well with resolution of her proteinuria at one point. And given that the obinutuzumab had been effective in controlling her disease, this was redosed in December of 2022. A few years later, she did have a rise in her proteinuria to with the UBC almost a 4, which prompted another biopsy in August of 2024. And the biopsy at that time showed class 3 nephritis with mild mesangial hypercellularity, with rare endocapillary hypercellularity, no crescents, but most notably had about 23% of global glomerular sclerosis and 16% segmental glomerular sclerosis, along with some patchy interstitial fibrosis involving about 5% of the cortex. So given how refractory her course had been up to this point, it was decided amongst our patient and our teams that participation in our CAR T-cell trial would be beneficial for her. To prepare her for that process, her Tacro had to be stopped, and here we can see her lab shortly after that most recent biopsy in August 2024 and prior to stopping her Tacro. Of note, her albumin was normal prior to stopping the Tacro, though she did continue to have proteinuria. And so in preparation for the CAR T-cell trial, she underwent a biopsy in December of 2024, about a year ago, prior to her CAR T-cells, and Robin will walk us through that now.
Yeah, so this is her biopsy immediately prior to CAR T therapy. You can see that she still has well-preserved cortex overall. There's a tiny bit of patchy interstitial fibrosis here, but it's really not bad. Looking more closely, the striking features in this biopsy were, as in the prior biopsy that Dr. Salvatore mentioned, increased global and segmental glomerulosclerosis, and here's 2 glomeruli showing that segmental sclerosis. We saw a little bit of mesangial hypercellularity and just rare segmental endocapillary hypercellularity in a small minority of glomeruli. There was one cell that was called a cellular crescent, and this is not the best representative image of it. Unfortunately, I couldn't find the slide that had the really good level of this cellular crescent. And then a minority of glomeruli had some mesangial hypercellularity. Interestingly, in contrast to her biopsies from 2020, the immunofluorescence in 2024 was much less bright. There was substantially less staining, but there was still discernible staining of IgG. IgA was now entirely negative. IgM was very trace and focal, and I do not depict it here. C3 continued to be positive, but in sort of a focal and segmental distribution, and there was still a little bit of C1q staining, but overall reduced. Despite the fact that IF had reduced staining, there was still plenty of electron-dense deposits by electron microscopy, which you can see here were present in a subendothelial and mesangial distribution. So this was called focal lupus nephritis. It's class 3, and it's got both an active and chronic component. There was one cellular crescent, global glomerulosclerosis involving 20% of glomeruli, and segmental glomerulosclerosis. And then we also commented upon the reduced immunoglobulin staining by immunofluorescence.
So she received her CAR T cells shortly after that biopsy in January, and is doing pretty well without clinical signs of active disease, and with her biggest issue currently being continued proteinuria. The graphs here on the right show her serum albumin on the top and her UPC on the bottom, and the temporal trends that you can see with stopping her tacro in October of 2024 and then receiving her CAR T cells in January 2025. Not included on this graph is that losartan was started around June of 2025. But the question that I know a lot of us are thinking about is what is the culprit of the proteinuria, and is it that the tacro had been stopped and now we're losing those anti-proteinuric effects? Is it a manifestation of just chronicity that we've seen on some of the biopsies, or is it a sign of continued active nephritis? So now we'll take a look at her post-CAR T cell biopsy. This was done about 4 months after that she received her CAR T cells.
So this is a biopsy from May of this year, and this is her most recent biopsy. This sample shows a little bit more interstitial fibrosis in this kind of patchy distribution. It does seem to be more prominent than in prior biopsies, although it's hard to say whether some of that is just reflective of sampling differences. Similar to the pre-CAR T cell biopsy, there continues to be focal mesangial hypercellularity. You can see a little bit of mesangial expansion in these glomeruli. There is continued segmental and global glomerulosclerosis to a degree that's, again, similar to the prior biopsies. And I think the membranous proliferative changes are, if anything, a little more prominent here, where you can clearly see some glomerular basement membrane double contours in capillary loops like this one, as well as this kind of overall kind of indistinct irregular appearance to the glomerular basement membranes. There were occasional hyaline thrombi present in this biopsy that you can see here, and just rare endocapillary hypercellularity, kind of to a similar degree as in the prior biopsy. Immunofluorescence continues to show staining that is present but reduced in intensity relative to a couple of years ago. So here's IgG, which is showing granular capillary loop staining. IgA and IgM were trace staining. C3 is also trace and with a more segmental distribution, as is C1q. And electron microscopy continues to show lots of chunky electron-dense deposits in the subendothelial areas as well as in the mesangium. And you can see that there is kind of variable effacement of foot processes. In some areas, they're quite effaced, and in other areas, there's relative foot process preservation. So this is, again, focal lupus nephritis. It's, again, class 3 with active and chronic components. It's got similar levels of global glomerulosclerosis and segmental sclerosis to the prior biopsy, and overall, the features are similar. So histologically, we're not seeing big changes following CAR T cell therapy. I am interested to hear what our nephrology team and what the audience thinks about this progression.
So I've been following Daphne since she came here and started following with nephrology. One of the things that we did note that changed after CAR T cells in all of these, looking at her in clinic and as definitely prior to this biopsy, is she did not have a active urinary sediment. She did have quite a bit of pyuria, which was a bit curious to us, which has since decreased. But there was a lot of discussion between myself, Sean Jackson, and Leah about what to do with her proteinuria. And it's a bit unsettling, as you can imagine. The part that we, don't really know and don't understand is obviously how long um, these findings in her biopsy would take to resolve if over time. So we leaned pretty hard on the urine sediment and what was going on with her clinically. Her complements are normal. Her double-stranded DNA is positive, but at very low level. And she has no clinical signs of active disease on no medication. So one of the things that so Sean obviously is a leader in this field, and he's running the REACT trial here. Talked to several colleagues. So he found out in the German trial, which is the longest trial for the CAR T for refractory lupus, most of those patients had lupus nephritis. That many of those patients were fairly new diagnosis. So they didn't have, a long history of lupus nephritis like Daphne has. Although they reported in the paper that they had no proteinuria, their CDI for that was 0, which is a UPC of 0.5 or less. Many did actually have some proteinuria, but they scored it as due to chronic kidney disease and not to lupus. And in discussion with some people who have done it on the US side, many are showing some proteinuria, especially if they had a long history of lupus. So it's to be determined what will happen in regards to her proteinuria and lupus, but we think clinically she's doing well.
Yeah, it sounds like despite the proteinuria, it sounds like she has benefited from the therapy. Do you think that suggests that longstanding lupus is a good indication for this type of therapy, or is it just too soon to say?
I think it's too soon to say. I mean, the German trial is now, I think, a little over 3 or 4 years out. So, and those patients are doing well. So it seems to be the right idea. It's who should get it. If they've had, a long history of lupus, what do we expect for chronicity and things like that. So that's the part we don't know yet.
Yeah.
Robin, could I ask, it looked like the immunofluorescence had decreased further in this May biopsy. The C3 had gone from 2+ to trace. Maybe the IgG was a little lower. But I was surprised by how extensive the immune deposits still were on EM. Did you notice, was there any decrease in immune deposits?
I think it's really hard to quantitate, but I asked myself the same question when I was preparing this slide set. And to my eye, I couldn't discern a decrease in the amount of EM visible electron dense deposits, which honestly surprised me. I think it's also curious, even if you go back to the pre-CAR T cell biopsy, where the immunofluorescence is quite faint. Here it's like 1+ or at most for C3, 2+. Even here, there's really quite a bit of of electron dense deposition. So it seems as though the two of them are not tightly correlated.
Robin, I wonder if some of this is also hyaline material too, which is hard to distinguish from immune deposits sometimes. There's clearly a lot of segmental sclerosis that's developing as well. So
that's fair.
Yeah.
Yeah, that you wonder in this loop where it looks like the capillary, where it looks like the lumen is pretty obliterated, whether that could be the case. Yeah.
Yeah.
Kim Yazinski. And I'm trying to remember this. Yeah, we didn't see a lot of hyaline in that particular biopsy, but we did see hyaline in this one, in the post-therapy one, for what that's worth.
Kim Yazinski here. Do you clinically follow complement levels C3 and C4? Because I'm wondering if, there's another component that needs to be addressed in the immune system aside from the CAR T, especially in light of the deposits.
We do follow complement levels. Yeah, her complements have remained normal. Not an extensive interrogation of the complement system though. So like we haven't done soluble C5b9, factor B, and all of those other things. We have not.
All right. Shall we move on to the next case, or does anybody have additional comments?
I just wonder when her next biopsy is. This was 4 months post-CAR T. We're now about a year post-CAR T. Is there another biopsy planned?
That's sort of what we recommended to Leah, that probably, sometime after the year, I think, and seeing what has happened since then, we'd be happy to do it here if depending on what you guys want to do.
All right. Move on to our second case, which will be presented by Dr. Yanofsky.
Thanks, Robin. Hey, everyone. Robin, will you give me a thumbs up if you can hear me okay? Good. Okay,
Great.
thank you. Great. I am a second-year pediatric nephrology fellow. I'm happy to talk about this case today. It was very, very tricky case for us. A lot of different pieces going on and difficult to manage. So the case is an 11-year-old female with C1q deficiency, complicated by severe lupus-like disease. With many manifestations, including mucocutaneous skin disease and mucositis. She came in for acute vomiting and headache with a hypertensive emergency. She developed fluid overload and also acute hypoxemic respiratory failure in the beginning of her course. 1 month earlier, she had actually been in for a subacute right temporal and parietal lobe stroke, and then continued to have residual left-sided weakness. This stroke was thought to be due to C1q deficiency arteriopathy. She was pulsed with steroids and then started a wean. She also started low-dose aspirin. When she was outpatient on steroids, she ended up becoming hypertensive, noted to be up to 160 systolic BP, and she was started on amlodipine as an outpatient by the rheumatology team. So when she presented, she was on 30 mg daily of prednisone. She had been managed previously on tofacitinib, and she was switched to baricitinib a few days before presentation, both JAK inhibitors. The switch was primarily related to insurance and side effect profiles. So on physical exam, very hypertensive. Reminder to our adult colleagues that different normals for pediatric blood pressure. And so for her, it would be about 109/72 is the 90th percentile, so less than that's considered normal. Although I'm sure if you see 180/133, you're going to know that that's abnormal regardless. She had a high MAP that's related to the 140/89. Heart rate, mildly tachycardic, higher respiratory rate, afebrile. So initially she was looking tired. She had facial edema and pitting edema to her shins. Her lung sounds were diminished at the bases. She had a distended abdomen that was non-tender, and you can see a discoid malar skin rash with hypopigmented patches and small brown plaques and severe alopecia. None of that being new at this presentation, but present from her existing lupus-like disease from C1q deficiency. So for her initial workup, I'll call out to you that she had AKI, so you can see her creatinine of 1.1 and her BUN of 47. She had elevated phosphorus at 6.5. Her albumin was actually okay at 3.5. Then if you look down at her CBC, you can see that she was mildly anemic at the time and had low platelets at 86. When we got a UA, very, very concentrated, 1.044 for specific gravity. And with that 3+ protein, knowing that it was a very concentrated urine, trace blood, but no RBCs seen, no leukocytes, and there were hyaline and granular casts noted by the lab. We got an NGAL to look at tubular damage, which was negative or kind of undetectable. Her urine protein to creatinine ratio was elevated at 2.88. For inflammatory markers, notably ESR was high at 44 and CRP was normal. C3 and C4 normal, but for total complement, CH50 was low. Soluble C5b9 was high, and it was higher at other points too. I'll talk a little about the peaks in some of these values, but this was the initial workup. She's ANA positive, not surprising, with lupus. She had LDH elevated at 576 and haptoglobin was undetectable. For imaging, so we looked at a renal ultrasound. The ultrasound was fairly normal other than having increased parenchymal echogenicity bilaterally. She got a head CT, especially in light of her recent stroke and with her significant hypertension and headache. And it was initially, the CT was concerning for press, but an MRI that was done after that was more consistent with neuroinflammation kind of picture. Notably, we got a CT chest angiogram to rule out pulmonary embolism, but we saw ground glass appearance, which made us think about a possible pulmonary TMA involvement. So overall, you can see from these labs that we have evidence of hemolytic anemia, we have thrombocytopenia, we have some signs of current inflammation, the ESR being elevated, complement systems active, at least with the soluble C5b9 and CH50 being low. And then her AKI at this time was mild, but, well, actually 1.1 for this age is actually pretty significant, but it got worse is really what I'm saying. So let's go to the next slide. So she was managed in the PICU on a nicardipine drip, metoprolol, a lot of other antihypertensives as well as the course went. She was also given eculizumab relatively early in the course, and that was more related at the time to it was more for the concern for TMA and the elevated C5b9. She did actually have initial improvement after that eculizumab, better blood pressure control, stabilization of creatinine. We thought things were going in a good direction, but then things took a turn again, and her AKI worsened. She had worsening fluid overload and serologic evidence of TMA. And so we then said we need to do a renal biopsy once we got her hypertension at a level where it was safe to do so. And I'll pass it over to, oh yeah, sorry, differential diagnosis. So we were wondering, is this renal TMA and or is this lupus nephritis? Because she had lupus, but had not had a lupus nephritis diagnosis. Notably before her presentation, there had been several months where she actually had a mildly positive protein in her urine. And so there could have been some starting at that point. So now I'll hand it over to Robin.
So at low magnification, she had well-preserved renal parenchyma. I think this isn't significant interstitial fibrosis. It looked pretty okay. All the action here was in her glomeruli, which diffusely showed mild mesangial hypercellularity. You can see a bit of that in these glomeruli. And then additionally, a minority of glomeruli did have some segmental endocapillary hypercellularity that's present, for example, here, maybe here, and in this glomerulus as well. The other thing that we could see is there was frequent remodeling of glomerular basement membranes, where you can see a lot of basement membrane duplication and irregularity. I think it's well displayed in this Jones stain, as well as in, for instance, this capillary loop in the PAS stain, where you can see some membrane duplication and double or maybe even triple contours here. In addition to this appearance of sort of a mesangial and membranoproliferative glomerulonephritis, there were also some evidence of thrombotic microangiopathy. Most prominently, there were a couple of arteriolar thrombi. You can see here on a trichrome stain, fibrin thrombi within arterioles here and here. And it also showed up in this Jones silver stain level where you can see an arteriole heading to or away from this glomerulus with a occluding fibrin thrombus within the lumen. And we speculated that perhaps some of the glomerular basement membrane remodeling here could also potentially be attributable to thrombotic microangiopathy. We did not see mesangiolisis, and we did not see intraglomerular thrombi. Immunofluorescence was interesting for this case. We saw granular staining that involved capillary loops and had a little bit of variation in intensity, as you can see well in this IgA stain, where some loops were staining quite prominently and then other areas more faintly. But there was, generally speaking, pretty much global staining. And there was staining for IgG, IgA, IgM, and C3. C1q was entirely negative, but when you consider that she has a history of C1q deficiency, perhaps that makes sense. So near full house staining, capillary loop, granular staining. And electron microscopy showed electron dense deposition that involved mesangium and extended out into capillary loops in a subendothelial distribution. There was no subepithelial component. And then here's another picture showing this is a capillary loop that's involved by endocapillary hypercellularity, and you can see these kind of chunky subendothelial immune complex or electron dense deposits. So we called this an immune complex glomerulonephritis with mesangial and endocapillary hypercellularity, and then commented that this looks like focal lupus nephritis class 3 with activity but no significant chronicity. Additionally, the presence of these fibrin thrombi supports a diagnosis of thrombotic microangiopathy.
Thanks, Robin. So then after her biopsy, she did develop end-stage kidney disease, or at least she progressed until she needed to have CRRT. The AKIs were repeating usually from sepsis. She had a hyperinflammatory state, refractory TMA for a good part of the time. And then she has her C1q deficiency, and then the lupus nephritis identified on biopsy. So she did receive obinutuzumab after that diagnosis, and anakinra for concern for HLH. She received a TPE centrifugal 12 sessions. So we had started it for persistent pancytopenia that she had that was of unclear etiology. We were thinking that there must have been some kind of pathogenic antibody contributing. And so we did TPE with some improvement related to the TPE. She was on CRT. Now she is on chronic hemodialysis. She's on 5 days a week, trying to reduce the number of days a week she was on, made it very difficult to control her hypertension. She continues on eculizumab chronically, although we do want to convert it to ravulizumab. She's on MMF, prednisolone, valsartan, and Hizentra. The kind of overall picture long term, there are discussions with BMT about getting a bone marrow transplant as a treatment for her C1q deficiency. She wasn't a candidate with her TMA being so active, and so under better control is when that could be in the conversation. She also is having a kidney transplant workup, and some thought of, if both of those are needed, of having them be from the same donor if possible. But these are conversations that there's still a lot to be discussed with those.
Thanks. Yeah, this was an interesting and complex case. Does her TMA seem to be under control at this point?
It is under control now.
And do you think it was sort of part of a manifestation of her hyperinflammatory state?
Ooh, it's hard to say. It's hard to say what caused the TMA. I see Daryl unmuted. Did you want to add?
Yeah, I mean, this is an incredibly complex patient. So, C1q deficiency, it's an autosomal recessive condition. Many, if not all of those patients go on to develop lupus. Her primary manifestations prior to this, as Stacy was saying, was primarily skin disease. That's what she had for a long time. Interestingly, her older brother also has C1q deficiency and has been doing really well. So family thought that, she might take sort of a similar course as the older brother because, the immunologist has been talking about, bone marrow transplant, for a while. The older brother has not manifested any signs of lupus. And it's sort of as Stacy laid out, her first presentation was with the stroke. And then she got discharged and then came back then with sort of fluid overload and malignant hypertension. It was sort of at that point that we felt that she was having signs of TMA. And, in retrospect, as it was evolving, it's more not just renal isolated. We think her CNS findings and her pulmonary findings were all manifestations of TMA as well.
Mm.
She was fairly refractory to a lot of, what we would do for a conventional treatment. So she was on the eculizumab, had some initial improvement, but then was very refractory. We had long discussions about whether it was her lupus or whether it was the TMA, and we landed on that it was primarily the TMA because she was still having sort of ongoing findings serologically of TMA with thrombocytopenia, anemia, and an elevated soluble C5b9 as well as an elevated LDH. So it wasn't until we started doing pheresis on her that improved. It took about a couple weeks of pheresis for us to see signs of actual improvement. So our thought was that there must be some antibody driving method, which is why we tried the obinutuzumab fairly early on. But it did take a while to resolve. But the TMA eventually did resolve, even despite stopping TB.
Mm-hmm. Any questions or comments about this case? I had never seen this before. This was super interesting. All right, we will go on to case number 3, presented by Dr. Okamura.
Yeah, so this is one of our other patients who's sort of had a long evolving history. So she went to end stage from crescentic IgA nephropathy, fairly aggressive. So she had a lot of crescents on her initial biopsy and went fairly quickly to end stage despite she got Cytoxan initially, and none of it really improved for her. And so she went on peritoneal dialysis until she got a deceased donor transplant in 2021. So not that long of a dialysis vintage for her on there. She got our standard high-risk protocol with 5 doses of thymoglobulin, methylpred, tacrolimus, and pred. As I was saying, she presented, at a fairly early age with aggressive IgA nephropathy with gross hematuria and proteinuria and an elevated creatinine. Robin, you can move on from that.
So her initial diagnostic biopsy was performed in early 2020. And at that time, there was, you can see a lot of interstitial inflammation and interstitial edema in this renal biopsy. And the most striking thing here was a widespread crescentic glomerulonephritis, where there were crescents of varying ages present in about 90% of the glomeruli. In addition, there's evidence of endocapillary hypercellularity. There's evidence of mesangial hypercellularity. But really, the main story here was a crescentic glomerulonephritis. Immunofluorescence, I'm showing you here representative images of IgA and C3. The C3 was a bit brighter, and then there was also a little bit of IgG and IgM that I'm not showing you, and we did not have glomeruli available for EM. So there was a little bit of ambiguity at the time of initial diagnosis as to what the nature of this disease was. We favored that it was IgA nephropathy. We had considered C3 glomerulopathy, but there was this strong IgA staining component. And we also talked about lupus because she had I think not super positive ANA, but in light of the minimal IgG staining and then absent C1q staining, we didn't think that was as likely. So looked to us probably like a crescentic IgA nephropathy.
Yeah, so this is what her pre-transplant course, which we kind of briefly talked about. She got, 4 doses of Cytoxan. She had a repeat biopsy to see if things had improved, which they, really hadn't. And so she eventually started peritoneal dialysis.
Just briefly, that repeat biopsy is shown here. So there's continued interstitial inflammation and interstitial edema present with probably a component of a bit of tubular injury. At that time, immunofluorescence was a little bit more consistent with an IgA nephropathy in the sense that IgA was now quite bright. There was still bright C3 staining. And the main change in the biopsy was there were fewer crescents, but there was now a substantial component of segmental sclerosis and global glomerulosclerosis.
So as you said, she went on to get a deceased donor transplant in May 2021. She had fairly significant hypertension pre-transplant, as well as some post-transplant. Then about 6 weeks after that first transplant, she had some increasing proteinuria. Her UPC increased from 0.2, less than 0.2 to 1. And so we underwent did a kidney biopsy for that. So here, yeah.
So this is her biopsy, first transplant biopsy, which was taken about 6 or 7 weeks after that transplant. You can see that we've got well-preserved cortex and the gloms look pretty okay. At high magnification, there were mild glomerular changes. So about a third of the glomeruli did have some mesangial hypercellularity, which I think you can see best in this trichrome stain. There was one glomerulus with some endocapillary hypercellularity, maybe here. I think that's mostly mesangial. And there was rare segmental sclerosis. But the main thing that we were seeing was some mesangial hypercellularity. And then immunofluorescence at that time showed quite bright IgA and C3 staining, as well as some IgG, which was almost exclusively in the mesangium. We also did electron microscopy on that transplant biopsy, which showed prominent electron-dense deposits that were mostly in the mesangium, but occasionally out in capillary loops, as in this image here. So this looked like recurrent IgA nephropathy.
Yeah, so we were quite surprised at the degree of glomerular involvement at that point. And so one of the things that was very tricky at that time is she had fairly significant viremia at that with BK viruses. So we're somewhat limited on what we could do in regards to the IgA. It's not shown there, but she did get, some small doses of methylpred. And we were watching where to keep her Tacro and her MMF doses. Unfortunately, with the small doses of prednisone, she did have worsening of BK viremia, and so she underwent another biopsy.
So this is her biopsy. We're now 5 months post-transplant with that bump in BK viremia. Cortex still looks good. And the glomeruli continued to show mesangial hypercellularity. It now seemed to involve more of them. And additionally, we were now beginning to see glomeruli with endocapillary hypercellularity. You can see that here. And then this wasn't quite enough to call a crescent, but it made us stop and think about the possibility. But there's definitely at least segmental endocapillary hypercellularity next door. We submitted, this was a limited biopsy, and we submitted all the tissue for light microscopy, so there was no immunofluorescence on this case. So this was called consistent with recurrent IgA nephropathy. We did not see BK nephropathy at this time, though.
Yeah, so given we were thankful not to see BK nephropathy, but because of her degree of viremia, we gave her some IVIG to try to address that. We kept her on a little bit higher dose of prednisone, but tried to lower her TACRO levels. And her BK levels got a little bit better, but then they spiked up again, as well as her creatinine. And so then we did another biopsy.
So this is now 7 months post-transplant. You can see there's a little bit of interstitial inflammation in the background. But the main problem now was that we saw abundant cellular crescents in this biopsy, which you can see, for instance, here and here, accompanied by endocapillary hypercellularity as well as mesangial hypercellularity. So this was beginning to look like a crescentic IgA nephropathy again, and the immunofluorescence microscopy kind of supported that notion with dominant IgA and C3 staining and also some IgG. It's interesting to look within this transplant biopsy at what happened with the IgA staining over that 5-month period. Here's the initial biopsy where you can see that the IgA staining is confined to the mesangium, whereas by December of 2021, there's definitely segmental capillary loop staining, and that reflects the progression of the disease by light microscopy. So this was recurrent IgA nephropathy, now with 33% cellular crescents, unfortunately.
Yeah, so we're really, in this really tough place between the viremia and worsening crescentic IgA disease. And as many know, crescentic IgA is a difficult beast to try to get under control. She had BK viremia, but she also had sort of intermittent CMV viremia. So the decision was made not to aggressively treat her with any kind of immunosuppression, since also her creatinine was continuing to rise. So she eventually went back on PD in 2022. Her PD course was complicated by some difficulty with volume removal. She was oliguric for the most part, and so she was activated on the transplant list and underwent a deceased donor in November 1st last year. We thought long and hard about what to do differently about her treatment this time. We were hoping that a longer time, since her initial IgA presentation, that her disease would possibly burn out, but it's always difficult to know that for sure. So even though the complement inhibitors that we didn't have, that we do have now with iptacopan and now atacicept, we decided to start her on ravulizumab as part of her transplant regimen. So she got thymoglobulin, 5 doses, methylpred, MMF tacro, and ravulizumab. So she did fairly well post-transplant. Her baseline creatinine was about 0.8 to 1. She was still at high risk from a viremic immune status point for CMV and for EBV. Her post-transplant course was complicated by kidney stones. Interestingly, her stent had a lot of calcification on it. So that made it sort of difficult to interpret her hematuria. So she had this sort of persistent hematuria that because of her history, obviously she underwent a surveillance biopsy at 3 months. When her creatinine was good, she had a UPC of 0.2, and she had sort of low-level BK viremia at that point.
So this is the initial biopsy of her second transplant. This was from January of this year, 2.5 months after that transplant. And by light microscopy, things looked really normal. There was no mesangial hypercellularity. The cortex looked good. Gloms looked good. Everything looked good. However, disconcertingly, immunofluorescence once again showed IgA dominant, predominantly mesangial staining, with some IgG, some C3, a smidge of C1q. We did not do electron microscopy at that time, and we just reported this out as mesangial IgA deposition with normal glomeruli by light microscopy. Could be early recurrence, but also a subset of donor kidneys do have mesangial IgA staining, usually not super bright. So hard to interpret what this meant.
Yeah, so because her clinical parameters were fairly mild, and there was no time zero biopsy to know if there was some underlying IgA to begin with, we decided not to invoke any treatment at that point with iptacopan. And as I said, she didn't really have any significant proteinuria. But then at around 9 months, she had an increase in her degree of microscopic hematuria. Her UPC did go up to 0.5 from less than 0.2. And then her creatinine was sort of running at the upper end of her baseline at 1. And so BK at that time was negative, but she did have a little bit of CMV viremia, and her DSAs were negative. So we did a biopsy.
So this time it looked like rejection, among other things. So you can see in this image, 2 small arteries with intimal inflammation. So there was arteritis present. This was diagnosed as grade 2B cellular rejection. And then in this image, I want to show you that there is tubulitis, as well as microvascular inflammation in the form of pretty prominent peritubular capillaritis. The C4D was negative and the DSA was negative, however. In addition to evidence of rejection, there was also now mesangial hypercellularity, which you can see best probably in this PAS and in this Jones stain. It was in a minority of glomeruli, only about 15%. And we did see one crescent, which I unfortunately did not have the slide that had the crescent on it, sorry. Immunofluorescence continued to show IgA dominant staining, which was predominantly, almost exclusively mesangial. And electron microscopy now showed, confirmed the presence of electron-dense deposits in mesangium and extending out into subendothelial capillary loops. So this was called T-cell mediated rejection grade 2A in light of the arteritis. There was microvascular inflammation, but no C4D or DSA. And once again, we were concerned that there were now features unequivocally consistent with recurrent IgA nephropathy, including mesangial hypercellularity, immunofluorescence deposition, and EM evidence of deposition, as well as a rare crescent.
So we were quite shocked that she had the 2A. We were, more wondering what the status of her IgA was, which also looked like it was progressing. And given her problems with viremia before and already having sort of a positive CMV, and her BK previously was positive, we just gave her 2 doses of thymoglobulin. And pulsed her with 4 doses of methylpred. We did start her on iptacopan and started her on losartan to address her proteinuria. Since she had the 2A on what we were giving her, we decided to change her to envarsus and sirolimus to try to better control her immunosuppression. Since we sort of didn't do like a full treatment that you would, expect for a 2A, we did a repeat biopsy at 11 months to sort of follow up on that. At that time, her creatinine was 0.9. She still had some low-level microscopic hematuria, and her UPC did jump up from 0.6 to it was varying to 0.6 to 0.9, and her DSAs remained negative. At that time of the biopsy, her viruses were negative.
So this is the most recent biopsy that we have. You can see it's from October. And at this point, her rejection had resolved, which was great. And glomeruli actually looked more normal than in the prior biopsy, which was interesting. We could see a little bit of mesangial increased cellularity, but it's kind of subtle. And then there was maybe one glomerulus with this segmental endocapillary hypercellularity that I think I found in the course of preparing for this conference. Otherwise, glomeruli did not have any endocapillary hypercellularity. There were no crescents. We did unfortunately not have tissue for immunofluorescence in this case, and we did not perform electron microscopy. So this biopsy was negative for rejection. That seemed to have resolved. And then we saw mild mesangial hypercellularity and just this one single focus of possible endocapillary hypercellularity. But notably, no progression, and in fact, probably histologic improvement relative to the prior biopsy that had shown evidence of recurrent IgA nephropathy. So that's where we are on this patient for now. I wonder, how has she been doing since this biopsy in October?
Yeah, she's been doing well. Her creatinine sort of has remained at its baseline. Her viruses seem to be in check a little bit. She still has some low-level BK viremia, but her other viruses seem to be okay. DSAs continue to remain negative. She continues to have some sort of low-level microscopic hematuria, but her proteinuria seems somewhat stable, at least at this point. So
is she continuing on the iptacopan?
She is continuing on the iptacopan, and then we did continue the ravulizumab. We're not quite sure what to do about that one yet. I think, the sort of thinking about the next steps for her would be sort of a BAFF-APRIL approach if things sort of get out of control. So that the data on that look obviously really promising. So that would be our next step.
And I guess this might be the first patient that I've seen repeat biopsies on who's received these relatively novel IgA-directed therapies. Is this your first experience using these?
Yeah, she's the first I've used it for other patients, like for iptacopan for C3GN, but not for recurrent transplant. This would be our first. I don't know if things are being done at the U for that. I don't know if you guys have experience with that medication for recurrent transplant IgA. Oh, I see. Yeah, that's the sibeprenlimab is the IV dosing, right? That's the once a month IV dose versus the injectable for the adatastat.
Yeah, it's subcutaneous.
That's
a month. So, from the iptacopan point of view, we were a site for the IgA study, and we have a few patients on that. But we're also quite excited by the anti-APRIL therapies. Much bigger drop in galactose deficient IgA1 levels, and obviously treating kind of an earlier point in the pathway. Complement inhibitors are a little bit further down the pathway.
Yeah, for sure. Yeah, she's at a better age now that we think we could get approval. Did you guys have difficulty with approval for the sibeprenlimab?
As far as I know, it's still in the process. Gao Yang did it actually move forward yet?
We just signed the paper. Still in process. Not sure when the patient can start.
Has anyone else had experience using any of these therapeutics directed against recurrent IgA in a transplant?
I think Ashley meant that because they were part of the trial. Ashley, I assume you meant.
Oh, the trial specifically for trial. Okay, cool.
At recurrent IgA and transplant, because transplant patients, I think, were included in that.
Got it.
Yeah, but these were all native patients, not transplant patients.
Oh, not transplant. Okay.
Yeah, I do not have experience using that, but I'm open to some of my colleagues who are also on the message. On the Zoom. I'm curious.
Yeah, the sibeprenlimab is for transplant patients.
Oh.
I think Nikolai has a patient with recurrent IgA on iptacopan.
Well, it's encouraging when early cases like this are so successful, at least appear to be at this point.
Would you guys keep iptacopan on and add a BAFF/APRIL blocker, or would you just go one or the other?
I think it would probably
I would
depend
let
on the course. You know, if she's doing well on iptacopan, I'm not sure I would continue both ravulizumab and iptacopan.
Yeah.
I'd probably stop the ravulizumab.
Mhm.
But if she progresses on iptacopan, then yes, I would definitely think about sibeprenlimab.
As a substitute or as in adjunctive to that?
Well, it's obviously very early days. It's only been FDA approved for a couple of weeks, so everyone's experience is very limited.
Yeah.
But you know, I think it gets more at the root cause of the problem.
Right.
So, you know, I might do both temporarily, but probably in the process of switching from one to the other.
Yeah. That seems reasonable.
I'm wondering if you do like both on top of the immunosuppressants in transplant patients. Were you worry about too much like over immunosuppressants?
Yeah, for sure. What was your first comment of doing both what?
So I'm wondering if you do both, are you going to worry about like give too much immunosuppressants and the infection risk will be too high and also malignancy?
Yeah, if you mean iptacopan and a BAFF/APRIL blocker. Yeah, agree. I mean, I would think I would lean towards Ashley's approach, which would be to start, get obviously if we add the other one, she's not in good control, and so then we would peel the other one away, the iptacopan. Great, thanks so much, guys.
All right.
Yeah, no, really interesting cases all around. Thank you.
Thank you, everybody. We will be back and presenting more cases in April or May. I forget exactly when, but looking forward to it. These are always a real delight, and we always get great discussion and really thoughtful comments from you. So thank you.
Thank you so much for sharing, guys.